Welcome. This is Jeff from Mend, and talking today about how we can reduce the risk of injuries within runners. We know that runners are one of the most commonly injured groups, with some studies showing up to 90% of runners will experience a running-related injury that will prevent them from training or competing at their desired level. So we'll be talking today about different strategies we can utilize, from the ones that are the most effective down to common ones that are utilized that are not as effective to help reduce this injury risk. So I practice at Mend. We're a sports medicine clinic here in Boulder, Colorado, really emphasizing the accelerated return of athletes to their individual sports. We tend to really pride ourselves on being problem solvers, getting down to the root of the problem, what's causing that patient's symptoms, what are the contributing factors, and really addressing those contributing factors as soon as possible to allow that, again, accelerated return of recovery. So we really pride ourselves on seeing patients for fewer visits with optimal outcomes versus that traditional model of seeing patients for 12, 16, sometimes 20 visits to get the patient better. So we initially had scheduled this talk for Neptune Mountaineering. We were going to give it on April 21st, but given the federal, state, and local guidelines on social distancing and avoiding large groups, we decided to cancel this event and instead put it online so people can enjoy the resources from their own homes. So as we mentioned, running is a very common sport, very easy to participate in, but also comes with a cost of a high risk of injury. Like I mentioned in the first slide, that 90% of runners will experience a running-related injury at some point in their career. And what we find is that the vast majority of these runners, if their injury is significant, don't return to the same level of training or competition after the injury. So even though the injury feels better, they're not going to achieve that same level of intensity or duration or frequency of days per week because the injury may not have been fully rehabilitated. The greatest risk factor for having a running-related injury would be having a previous injury. So again, you took time off, you avoided running, maybe you reduced your volume of running, the injury felt better, you returned to running, but the injury itself never got back to 100% strength. It never returned to the same level of resiliency as it had before the injury, and that can become that greatest risk factor for a second injury. As you would imagine, some of the most common areas we would see pain would be at the knee. That pain on the front of the knee, commonly called patellofemoral pain, IT band pain, tendon injuries at the knee, and then also at the foot and ankle, thinking about Achilles tendon pain, and also plantar heel pain, or what we used to call plantar fasciitis. Some of the most common pathways for these injuries would be that overuse nature of injury, where the load or the running volume had exceeded the tissue's capacity, and that's commonly why we see that the greatest risk factor is that previous injury. The tissue still has a limited capacity. You try to increase your running volume, and as soon as that volume exceeded the tissue capacity, we developed that overuse pattern of injury. In addition, thinking about that same line would be the training errors, doing too much too soon. That's a common subjective complaint or subjective history that we find in our injured runners. They did too much too soon. They tried to rush their training program. They didn't use a good online platform or a good coach, and they set themselves up for that training error. And then finally, we know that in many sports, having poor mechanics is not an absolute indication for injury, but it certainly can contribute. So the difficulty of these running-related injuries is they take time to heal. And I would really caution an injured runner of finding any provider that can promise quick results and quick treatments for given injuries. If we look at this study that was done a couple years back, really the average time of getting back to running after an injury was 8 weeks, so 2 months of recovery. And that could range from a meniscal injury in the knee, close to 90 days, or plantar heel pain on the shorter end being about 35 days. So as you can see from this chart, significant time once injured, and especially in injuries to tendons that don't have a great blood supply, they really require a longer healing time to get back to their full capacity and their full resiliency to loading. So in our clinic, we commonly find two broad categories of impairments. We would put people into a mobility impairment if they had tightness or restrictions in movement, and then we put people into a stability impairment if they found weakness or lack of muscle performance or motor control of those injuries. What we can find is that across the board on these different rows, we see different types of injuries, and commonly we'll find distal impairments of mobility, in the ankle, for example, where the ankle is not bending properly, maybe the foot is not moving properly. And then we see a lot of stability issues in those proximal areas like the hip, the knee, and sometimes the core in our injured runners. So one of the old wives' tales that's out there, and you still hear it unfortunately, is that running causes arthritis. That we want to try to avoid running because we don't want to worsen our arthritis, or we don't want to have the development of arthritis. And what we find with the newer research in the last 5 or 10 years, this is really being questioned in the research. Is that a true statement? Do we really develop arthritis if we're active and we use our knees? Or if I have arthritis, will it get worse if I continue to exercise? And what we're finding is actually the reverse is true. In this first study by Lowe in 2016 that we'll discuss, they looked at 2,500 participants. And what they found was that 1 in 3 of these participants were runners, either former runners or current runners. And what they were doing was they were looking backwards through these patients' cases to see what factors contributed to the development of arthritis. And did they find a significant correlation between history of running or volume of running and the development of arthritis at the current time? So they were kind of looking for those osteoarthritis or arthritic risk factors. And what the authors concluded was that there was no increased risk of knee arthritis among the running participants. And then they concluded that running does not appear to be detrimental to knees. So they did not find that running was correlated with the development or the presence of arthritis at the time period. And then the common question would be, does running worsen my knee arthritis? You might be a middle-aged runner with knee pain. You may have had an x-ray that showed arthritis, which is not uncommon for us that are over 30 years old. We start to see the arthritic changes develop after age 30. And in this study, they looked at 1,200 runners. They were all over 50 with signs of knee arthritis on x-ray. And what they did interesting was they gave them an x-ray at baseline, and then they had them follow up at 4 years. And at 4 years, they gave them a second x-ray. So they could compare the second x-ray to the first to see if there was any difference in severity of arthritis. And what they found in these runners, these 1,200 runners, was that the running did not worsen the structural arthritis on x-ray. So when the radiologist read the second x-ray, there was no significant differences between the second x-ray and the first. And what they concluded was that self-selected running need not be discouraged in people with knee arthritis. So again, we're not going to discourage everyone across the board not to exercise and not to run because of knee arthritis. So I think a common question you might have right now is, how does the volume of running impact that? Clearly a runner who runs less will have less forces across the knee than a marathon type runner. And so in this interesting review of the research done in 2017, authors looked at 24 studies of 123,000 runners. And they wanted to look at what's the relationship between running volume, right, the amount of minutes you run per week or the intensity that you run per week, and then that development of arthritis. And what they found was an interesting curve where they found that the highest group, the highest incidence was only about 13%, and that was among our professional runners. So you might categorize those people that are running multiple marathons in 1 year and competing at a very high level with a very high training volume. And the second most common group, surprisingly, was our sedentary people. So a sedentary individual would have a 10% incidence of arthritis. And then what I liked about the study was they showed a protective effect if you're a recreational runner. So if you're a recreational runner, you had about 1/3 the incidence of a sedentary control at about 3.5% incidence. So again, if you're a recreational runner, we think that running may have a protective effect. It's going to improve the metabolism of the tissue, especially the cartilage at the knee, helping with the circulation to the cartilage. One of the interesting things about cartilage is it doesn't have a great blood supply. It really requires the diffusion of blood and also kind of the diffusion of waste across the knee. So if you're more active, you get a better circulatory effect at that knee cartilage. So again, we can kind of disprove that running does cause arthritis, and then also running does not worsen arthritis in the vast majority of cases. So if we look at our injury prevention strategies, we're looking at 4 broad categories. We think about this pyramid model that the ones we want to use sparingly would be things like our shoes, orthotics, and lifts. And as we come to more of the ones that are more effective, we look at things like strength training. And then probably most importantly is your training volume. It's how you control your training volume from 1 week to the next to avoid those training errors and that common pathway of injury. So there's that famous commercial in the 80s or maybe 90s with Michael Jordan and Spike Lee where Spike Lee said it's got to be the shoes. Well, when it comes to running, it probably is not the shoes. And what we're going to find is that the shoes don't make a big difference on injury risk and prevention, but as long as you stay within what we consider the average or the bell curve of the shoe type. So what we'll start with first is drop. And we know that drop has become a very popular term with runners, thinking about the zero drop shoe, where we see a decrease in depth or reduction in height between the heel and the toe. And in a study that was done in the American Journal of Sports Medicine, they looked at 500 runners, and they wanted to see if they were randomized to different shoe drops. And the first group received a zero drop shoe, the second group 6 millimeters, and the third had a 10 millimeter drop in their shoe. And what they did is they followed these runners for up to 6 months, and what they found was that the injury risk was not modified by the shoe drop height. So again, there was no difference if you chose that minimalist shoe or that medium shoe or that cushioned shoe on injury risk. So if you think about the group that's most interested in trying to prevent running-related injuries, it would be the U.S. military. Because again, these recruits are coming in, they're being put through boot camp and different training procedures, and what they're looking for is trying to reduce that risk of injury to their new recruits. You could imagine the risk and the cost associated with an injury with these new recruits, and if we can keep these recruits healthy, they want to do everything they can in their power to help them participate in the training without having an injury risk. And what they've done in these 3 really large studies is looked at a recruit's foot type. Are you more of a flat-footed foot or a more pronated foot? Do you have more of a neutral or mid-range foot? Or do you have a high arch, what we consider a supinated or a stiff foot? And in these 3 large randomized controlled trials, they tried to match the individual's foot type. Was it flat? Was it high? Was it neutral? To a shoe. So for example, with a pronated foot or a flat foot, we oftentimes would think we need to give that patient a motion-controlled shoe. And with a high arch or a supinated foot, we oftentimes think we need to give that patient a cushioned shoe. But what they found in their research was that when they matched the footwear, it had no effect on future injury. So if you were matched to the right shoe or if you were given the wrong shoe, in that kind of thinking about cushion versus high arch shoes, it did make a difference on injury risk. So again, it's probably not the shoes that's going to make the biggest reduction in your injury risk. What we also tend to think about is that maybe a heavier shoe or a cushioned shoe is going to require more work, including more energy, like fuel and oxygen. So it may reduce our running economy, which is kind of like our miles per gallon when we run. And running economy is one of the main indicators on running performance. Right? Can you run at the same speed as your friend or your peer, but burning less oxygen at a lower intensity? So they took healthy runners in this study, and they randomized them to 3 conditions. The barefoot condition, a minimalist shoe, and then more of a mid-range shoe. And they had these runners run at about 50% and 75% of their VO2 max. And what they found was when we gave people less cushioning, they ran with a higher stride frequency. And what they didn't find was any change in running economy between the groups. So it really didn't matter which shoe you wore, but inherently there was a reduction into a higher stride frequency with a decreased step length if you had less support in your shoe. So what we would recommend given this is that inherently you know what's a good shoe and what's not a good shoe. I can remember starting my career and taking many measurements of a patient's foot and ankle and then prescribing a shoe based off of those measurements. And what we're doing on the big studies now is finding that inherently as a person, you know what's a good shoe and what's not a good shoe. So we really recommend that when you try that shoe on, and even better if you can find one of our local running stores that allows you to run in these shoes for sometimes 2 to 4 weeks and then return them, that's a great way to trial out these shoes. I'd really recommend you choosing more of a name brand shoe, staying in that bell curve of shoe types. Don't pick the extreme of minimal cushion, and don't pick that extreme of significant cushion unless you have an atypical foot type. If your foot resembles something that's out of the bell curve, you might require something like a different shoe. What we find is, again, pick for comfort. That comfort selection is probably the most important variable of picking the right running shoe, picking a shoe that fits well, that feels good, especially, again, if you can try it with the 2 to 4 week trial that a lot of running stores will offer. So a lot of our running shoes will have a lot of miles on them, and they kind of look like these shoes on the right where you loved the shoes, you didn't want to get rid of them, and so you held on to them as long as you could. And again, what we find is that this is associated with running injury. because what tends to happen is the midsole that provides most of the cushioning for a running shoe breaks down before the exterior parts of the shoe. So if you're using only exterior, maybe observation or looking at the tread at the bottom of the shoe to determine when you should recycle that shoe or turn it over to yard work, what you're going to do is you're going to kind of reduce the midsole cushioning and maybe put yourself at risk for that running related injury. So most manufacturers will demonstrate that they lose about half of their shock value, kind of shock absorption, at about 250 miles. And then most manufacturers will recommend that you replace the shoe between 300 and 400 miles. So again, observation may not be the best method of determining if you need to recycle your shoe. Instead, try to keep a training log of how many miles you put across this shoe and then recycling that shoe as needed. Finally, you can also do a spring test that when you compress the shoe from toe to heel, it should kind of bend where the toes would bend. And if you find that it bends more in the middle of the shoe where the arch would be, then you can determine if that midsole might have reduced its shock absorbing capacity. So orthotics are another thing on the top of our pyramid where they're easy to use, they're easy to buy, and they don't require much hard work. But like most things in life, the harder you work, the more you're going to get out of that benefit. So when we look at orthotics, the vast majority of people don't require orthotics, and oftentimes in more of the studies that the custom orthotics that are very expensive, sometimes 10 times the cost, do not outperform the ones that you can buy on the shelf. So if you do require an orthotic, I'd recommend the ones that are off the shelf that are much less expensive, unless you have a very atypical foot. If you're outside that bell curve, you might require the custom orthotic, but the vast majority of runners do not require orthotics, and the vast majority of running shoes have become so much better nowadays with technology that they really have kind of a built-in support system, and they don't require any kind of external orthotic plus the running shoe. A lot of studies have shown that the biomechanical changes at the foot and ankle occur due to the shoe, and there's no additional effect of adding an orthotic onto a good running shoe. So in this study by O'Connor in 2016, they wanted to kind of group runners by the degree of foot motion. So did you have a lot of flattening of your arch, like a pronated foot? Did you have minimal movement, like a high arch or a supinated foot? And what they did was they gave the runners who had the most motion at their foot, the pronators, for example, they gave them an orthotic. And what they found was that orthotics did not significantly impact hip or knee mechanics. So this idea that we're going to put something in your shoe and we're going to make your back feel better, your hips feel better, your knee feel better, is really controversial and probably untrue. And you can even see it up the chain. People will mention that their mid-back pain will feel better with orthotics, and I think we're getting too far down the line. I think the best we can probably do is try to control foot and ankle motion, but we're not going to see much change above that into the knee and hip. So we know that our foot is a remarkable structure. 26 bones in the foot, really designed to move and then become rigid as we push off of our foot. So it's one of the main reasons why we evolved, and one of the main reasons we evolved as a species in the ability to run. And what we find is that the springs, the arches in our foot act like springs, and they help absorb energy and then push off, and we get that energy to help us in the performance of running. So what they find is that 17% of your energy when you step on your foot is absorbed and then transmitted into the push-off phase of running. And these foot arches are great for energy conservation, but what we find is that in runners who use more supportive shoes or more orthotics, we see that there's a greater energy cost and lower running economy because you're not getting that spring effect. So again, we know that there's a benefit of our feet. They're remarkable structures, but they're probably designed to move. So we don't want to oversplint something or undersplint something. So again, picking a comfortable shoe that may require your foot type, but trying to avoid overbracing the foot with orthotics or a really supportive shoe. We also find in runners that who use orthotics for a long period of time, they can develop atrophy in their foot muscles, and these individual intrinsic core muscles of the foot that span from the heel to the toe, they're extremely important for supporting the arch of the foot. But if you overbrace your foot with orthotics or stiff shoes, you tend to see atrophy or weakening of those muscles, which may be a risk factor for the development of what we used to call plantar fasciitis or plantar heel pain. So we also see that a lot of injured runners come in and they've got different heel lifts in their shoes. Somebody's told them that their legs were different lengths, so they needed to even out those legs in order to reduce that injury risk. And most importantly, what we find is that the vast majority of us are not symmetrical from right to left. There's going to be differences in lengths of bones from right to left, and many of this is normal. And what we're going to find is that it's going to be the degree or the difference between sides. It's going to be the most important factor to determine if you need a lift. For example, one of our top runners, Usain Bolt, fastest man on the planet, has a significant leg length discrepancy, and you can see that when he runs, and he also has a structural scoliosis. But given his high level of performance, you're not really going to find any clinician that's going to be willing to put something in that guy's shoe. So again, you can perform at a high level with differences from side to side. It's really going to be about the degree of difference that's the most important factor. In this study in 2018, they looked at that degree of difference. And they looked at 300 distance runners. They were all screened for leg length and then followed for up to a year. What they found was that 1 in 5 had a significant leg length discrepancy, or a difference in length from side to side. But they did find that this discrepancy was not associated with injury, except, and this is the big except, if that difference was more than 1.5 centimeters, they were 7 times more likely to have a future injury. So if your leg length is more than 1.5 centimeters different from right to left, you might be a case of we might want to add something into your shoe to level out the positioning between right and left sides. One more caveat on this is that most of our clinical measurements of leg length, using a tape measure or using observation, are very poor as far as reliability and validity against gold standard measurements of leg length discrepancy. The gold standard remains a standing x-ray, where we look at the pelvic landmarks and the hip landmarks and doing a standard x-ray to see if there's any significant differences from side to side. Again, if your clinician is relying only on tape measure measurements, that's going to be questionable if that's really a true leg length discrepancy or is that a measurement error. So one of the cool things that I think has come out in the research in the last 10, 15 years has been the impact of gait retraining with a physical therapist, and really using gait retraining to improve those mechanics across the runner to reduce that injury risk. If we look at the left side of this diagram, we can see the red arrows are indicating that her pelvis is sloping down from right to left. That usually indicates that there is weakness on the right side of the glutes, and those glutes are not able to control the pelvic position. There's also a decrease in the window between right and left knees, where the right knee is angling to the inside. We call that a valgus position. And there's decreased space between the right and left knees. If we look at the picture on the right, that's what can occur with gait retraining and visual or auditory feedback. And that patient can keep their pelvis level and also improve that window between the right and left knees. So again, reducing that risk of knee pain like patellofemoral pain or IT band issues or tendon overload that we commonly see with poor mechanics. So what we find with running mechanics is that there is not one ideal running gait. And don't believe it if you read it, don't believe it if you hear it, that we want to put all runners into the same gait pattern. There's significant variability in our running gait patterns, and especially in healthy runners, there's no reason to take a healthy runner and change their mechanics unless you're at the extremes of the mechanics. Oftentimes what we'll do is that we see in the evidence it's much more supportive to change an injured runner's mechanics than it is to change a healthy runner's mechanics to try to prevent injury. One of the common measurements we might look at would be the amount of steps you would take in a given minute. And what we find for the most average runners is you're going to run between 160 and 180 steps per minute, with elite runners running at 200 steps per minute. And as you can imagine, that would be higher step frequency. So they're taking more steps per minute. And then conversely, what they're going to do is reduce their step length. So if you're a longer runner, a taller runner, you may take longer strides with a lower step cadence. And if you're a shorter runner, you may take shorter strides with a higher step cadence. In that inverse relationship, we're going to see over and over again between the stride length and the stride frequency. So again, we're going to try to change stride length or stride frequency in an injured runner, but we don't have as much supportive data to change those variables in a healthy runner. So we have two main categories of running. We see heel strikers. These are usually your taller runners. You can hear these people coming down the Mesa Trail behind you when you run. They're very loud runners because they're landing with their heel. And in this heel strike position, they've got less knee bend, and so the quad muscle is not as effective as a shock absorber as more of a midfoot strike. So what we're going to see is greater ground reaction forces in this runner. So that could indicate more back pain, more hip pain, more knee pain, because again, the muscles are not able to be shock absorbers and reduce those ground reaction forces. But again, this could be a patient that we put into a heel strike if they had Achilles issues. So there is some trade-off that we'll discuss here between heel strike and midfoot or forefoot strike. So in the forefoot strike pattern, often associated with more of a softer runner, it's harder to hear them coming behind you on the trail because they have more of a knee bend and they have more of an ankle bend. So again, better shock absorption between the calf and the quad to reduce those ground reaction forces. Oftentimes this runner, as they have that inverse relationship, they have a shorter stride length, but they have more stride turnover. So they have more steps per minute. Their cadence is going to be higher. So if we have these two broad categories with injury, what we see in the heel striker is greater ground reaction forces. They can be at increased risk of many issues, from knee pain to stress fractures to plantar heel pain or plantar fasciitis. And what we see also is that up the chain is going to be affected as well, because that force has to be absorbed somewhere. And if it's not absorbed by the local muscles, it can be transmitted up into the hip or up into the back. And then conversely, in the forefoot strike, what we see is that those patients are going to run with a higher stride frequency. They're going to get more steps per minute with a shorter stride length and have reduced ground reaction forces. Now, the flip side of this would be that those patients, because they're working harder at the calf and the quad, can be more prone to tendon injury. So it could be more issues like quad tendinopathy or quad tendonitis. We used to call that tendonitis. Patellar tendonitis, now we call it more tendinopathy, and also Achilles-related injuries too. So I try to think of these heel strikers as like the Hulk. They kind of run like the Hulk. They're loud, they're noisy. You put them on the treadmill, you're really worried about the structural integrity of your treadmill when they're bouncing around at the gym. You can kind of definitely see where they are in the gym, and you can hear where they are in the gym. So looking at this study by Davis in 2015, they wanted to see are these gait mechanics associated with future injury? Can we look at a patient who's running and maybe determine if they might have a risk of future injury? We mentioned that there isn't any ideal form of gait, but there are outliers that we can try to modify to reduce that injury risk. So in this study of 250 healthy runners, they gave them all gait analysis, and they followed them up for 2 years. And what they found was that 88%, close to 90% of them reported an injury over the 2-year period. And what they found was associated with this injury was a high vertical oscillation. So instead of moving straight ahead, these runners bounced up and down. So they had more vertical oscillation. So they kind of bounded up and bounded down. It's kind of a waste of energy. It's going to reduce performance because in running, the only thing that matters is how fast you can move straight ahead. And if you spend any energy going up and down, you're going to reduce performance. In addition, you can increase that injury risk because the more you move up and down, the greater the ground reaction forces across your lower body. And also what they found associated with the injury was this Hulk type pattern of running where they ran with a hard or loud foot landing. So we know it's associated with injury, but can we make a difference if we do gait retraining? So in 2015, what they looked at was about 40 runners. Half were rear or heel foot strikers, and then 50% were mid foot strikers. And they had them run at the same 7 or 8 miles per hour, but under 3 different conditions. The first condition they had them run at was their own self-selected running pace. So however you like to run at home, we want you to run the same way on this treadmill. Then they asked them to shorten their stride length by 5%. And remember that inverse relationship, that if we reduce the stride length, we're going to increase the stride frequency. And then the final group was to reduce it by 10%. And what they found was that the biomechanics were improved or altered as we shorted the stride with greater stride frequency. And in particular, what they found was, remember that first picture that we had with that woman on the left versus the woman on the right? There was an improved pelvic drop, so their pelvis stayed level, and they had better knee mechanics if they had shorter strides. So in a weak runner, if we can reduce the amount of time they spend on the ground, we can wait for the hip to get stronger with exercise by making these small gait adjustments. So that's oftentimes what we'll do in the clinic to keep a patient running is look at their gait mechanics. What can we change today to keep you running despite the injury? And then while we're waiting for this hip to get stronger, we can use these gait modifications and then wait for that hip strength to catch back up. So again, how can we look at reducing the knee forces in runners? So we know that we can improve mechanics with gait retraining, but can we reduce the knee forces, which we think are associated with future injury? So again, taking healthy runners, and again, putting them into the 3 conditions, but this time, in addition to shortening the stride, they asked them to lengthen the stride by 10%. So we had those 3 different conditions. We had runners, and what they found was that regardless of what foot strike pattern you used, if you were a heel striker or more of a midfoot striker, if you reduced your stride length by 10%, that was associated with the lowest amount of knee forces. So again, an inverse relationship between stride length and stride frequency. And for the best combination of reducing knee forces, they found that more of the midfoot strike with a shorter stride length had the decreased amount of knee reaction forces from the ground as you land. So in a patient with knee pain, one of the main things we can change is get them into a midfoot strike and reduce their stride length, right? Go to 10% shorter. So we mentioned that in that first study we discussed with the Hulk picture, runners that had more vertical oscillation, that did more up and down movements, had greater ground reaction forces. We call that high braking forces. So instead of conserving energy and pushing themselves straight ahead, like in this second picture with the green line, we want all the energy pushing you forward. The top runner wasted energy going up and down. And if you're wasting energy going up and down or vaulting on the treadmill or on the track, you're going to have more braking forces and more ground reaction forces. So what they did in this study was they looked at runners who were training for a half marathon. And they included everyone who had this high vertical oscillation or high ground reaction forces. They gave all the runners 8 biomechanical training sessions with a physical therapist, trying to improve that braking force, try to reduce the amount of braking force, make them a more efficient or a low force runner. What they found was after the training sessions, there was a reduce in step length. Again, the inverse relationship was preserved, where we saw an increase in step frequency, and they reduced the peak forces across the body by 15%. So it's a very significant reduction for these athletes that were training for the half marathon. And as you can imagine with any type of training, whether it be golf or cycling or basketball or skiing, the more you practice the individual training technique, the more familiar it's going to become. So it's becoming less conscious, and it's going to become more unconscious or natural with the more training. And that's what they found by the end of the trial here. So you're probably wondering, how do you do that? How do you reduce braking forces? How do you reduce force across the knee? And really, it's kind of simple. We tend to find with runners, they're a very analytical group. They tend to analyze everything, whether it be training peaks or their online formulas. They're very much an analytical type of athlete. And what we tend to find with that analytical athlete is that the more cues that we give them, they get into this paralysis by analysis, similar to what we see in a golfer. If we give a golfer 7 things I want you to work on before you hit that ball is going to sail right or sail left. So it's better to give that athlete or that golfer fewer cues because of that analytical nature of the sport. So what they did in this study was they looked at healthy runners and they analyzed the gait forces across the treadmill under 3 conditions. Right? We see the same self-selected running, an increase in step frequency with a decreased vertical oscillation. And what they found was that there was a greatest reduction in forces seen when they cued for the vertical oscillation. So everything else kind of cleared up if we gave the runner less things to think about with just a simple cue of land softer. So when you're running, if you can really think about your landing and use that auditory feedback of your heel strike or your midfoot strike and just try to land softer, that's going to help you reduce those braking forces and reduce the ground reaction forces across your leg. So if you had to think about anything, the one cue we often give our injured runners is just try to land softer. And just thinking about that one cue, your body's going to figure it out, how to reduce the forces across the leg. So in Irene Davis, who's one of our top physical therapy researchers, she's at Harvard looking at injured runners. The New York Times did a really nice nice article looking at all of her studies that she's done. And they interviewed her as to see who are the people who don't get injured. Like who is this 10% that's never had a running related injury? And Irene Davis mentioned that these runners are hard to find, but the runners that they have seen in the clinic that have not experienced any running related injury have landed very softly. And it was kind of a very graceful running style, very soft, very quiet, kind of imagining somebody running across the water, spending very limited time on the ground, a really fast turnover, and again, just landing softer. So that'd be the one cue I'd recommend that you go after, is trying to really use the auditory feedback to reduce that vertical and ground reaction forces. Don't think about everything. Don't get into the paralysis by analysis. Really just try to focus on just the auditory feedback. So as we move down the pyramid, we can see that the more time we put into these interventions, the more benefit you're going to get. And I love this quote, thinking about injury, that those who think they have no time for exercise will sooner or later have to find time for illness. We often see runners that say, I just don't have time to do strength training. Or some female runners might say, well, I'm worried that if I do strength training, I'll bulk up. And really that's been disproven in a lot of the research is it's shown that we can improve a runner's strength without any change in their body mass. So a lot of these barriers to strength training, whether it be time or maybe irrational fears about putting on weight or bulk, have been disproven by the research. But we do know that strength training is very beneficial across all sports for reducing that risk of injury. So in this large review of the literature of over 26,000 athletes, what they found was that strength training reduced the risk of overuse injuries by a half. So it was a significant reduction in injury risk if that runner was also working on strength training. And what we also know from strength training is that it's going to improve your running economy and your running performance. So there's a great kind of twofold benefit there. Looking at running performance is going to improve as well as reducing that injury risk. So what we recommend for runners is that working with a physical therapist to design an exercise program for you that's individualized to you, but in general in 4 broad categories. Choosing a squat movement, a hinging movement, choosing a core exercise, and also choosing an ankle exercise, in particular plantar flexion or calf strength. Aiming for about 2 to 3 days per week, depending on your training cycle. As you get closer to a competition, we'll probably reduce that strength training volume down to maybe 1 day a week or even giving you a day off, obviously. And as you move towards the off season, you're oftentimes going to be doing less run training, and you're going to have time for more cross training and then also strength training, getting up to maybe 3 days a week. We want the exercise to be fairly intense, aiming for about 70 to 80% of your 1 rep max. And also choosing a rep range, usually around 8 to 12 repetitions. Of course, this can be varied, but also trying to find a set that you can finish with 8 or 12 reps with good form. But if you finish your set of 10 or 12 repetitions, and you could have done 5 or 7 more reps, that weight was probably too light. And if you can't get to 8 reps, that weight was too heavy. So try to choose a rep range first, 8 to 12 reps, choose a weight, and try to make sure that when you get into that rep range, when you finish the set, you've got maybe 1 or 2 left with good form. We call that repetitions in reserve. If you could have done more than 2, you need to bump that weight up. So we have on our YouTube page, we've got excellent videos for runners. All of these videos I'm going to show you here are on there. You can go to YouTube, search for Mend Colorado, and our videos will pop up. So thinking about our run progression, I'll let this play. So this is a vertical strength development. Choosing an exercise that would help you with your vertical strength, oftentimes again in that squat category. So we've got different variations for the exercise. This is a goblet squat here. Thinking about a front squat or a back squat. Again, there's going to be some pros and cons to different exercises. That's going to be an excellent way for you to choose one of these exercises working with a physical therapist, what's most appropriate for you. So you don't have to do all of them, of course, but just choosing one that you feel is most appropriate for you, and moving back into the back squat. So squatting is a great way to develop vertical strength. It's hard to beat the squat for muscle activation. It's a great compound movement that's going to strengthen the core, back, hips, and knees. And then finally, the Bulgarian or split squat. That would be an excellent way to train one leg independently of the other, so you can really get the most benefit out of those legs. Running is a very symmetrical sport. We want to have equal force production out of each leg. And then finally the step up here. And if we get into our horizontal strength, this becomes more of our hinge category, thinking about deadlift type movements. So it may be at the gym you're going to use a barbell, thinking about a Romanian deadlift, really working on that hinge. So it's a great posterior chain exercise for our low back, our glute max, our hamstrings, and also our calf. So again, trying to get rid of that old myth that if we put runners into a strength training program, they put on mass, which can affect performance or body image. And what we just really don't find that. We see that runners tend to improve their strength, but we don't see an increase in body mass. So body mass, bulk, or hypertrophy is a very different thing than strength gains. So as we move from both legs to a single leg, the kickstand deadlift is an excellent stepping stone. You can use the back leg as a support system, but the front leg does all the work. So as you're trying to transition from both legs to a single leg, this is oftentimes a great stepping stone. So now we can see her moving into a single leg deadlift. Again, training legs independently of one another to get that strength balance back. We also have options for how to improve your deadlift. So that's a very difficult movement to work on, especially keeping your back out of it, trying to keep your back arched or extended, and really optimizing the motion at the hip. So if you watch her hip joint, and you can see it on her shorts, we want to see a really nice hinge at the hip. And you can see where that crease is occurring. We want that crease to occur at the hip, but the back for the most part is coming along for the ride. So again, excellent video resources on our YouTube page for how you can progress your hinges. And as we look at the core, it's a very umbrella type term. We all tend to use it, but what does it really mean? And there's a lot of muscles that are involved in the core. The front of the body, the side, the back of the body are involved. And what we tend to find is our injured runners is they do front planks for 2, 5, 10 minutes. It's very impressive, but it doesn't really reduce their injury risk because they're probably doing an exercise they're already good at. And they're trying to avoid the exercises they're not very good at. So the goal of the Bunkie test is to identify your core weakness or your weak link by looking at all different sides of the core. So we're looking at static holds, looking at the side in the top picture, the back in the middle picture, and then the front in the bottom picture for which part of the core is weak. So if you can't produce the movement for 40 seconds, or if it's painful, or if there's any reason with compensation, that would be considered a positive test. And that might indicate you need to work on that area. So for an injured runner, rarely do I find that the front of the body is weak. What I commonly find in my physical therapy practice is that the side of the body is weak, or maybe the inner thigh is weak for that patient. So in the Bunkie test, we'll play this here we have this video for you guys as well. So in this position, you can see that we're testing the outer hip, looking at outer hip strength, glute medius, maybe the obliques and the core that are working hard here. Again, trying to hold for 40 seconds to see if that's weak. If we see a side-to-side difference, or if they can't hold for 40 seconds, that would be indicative of a positive test. This is more for the anterior or front of the body. Again, it should be pain-free. You should have good mechanics, but if you can't hold it for 40 seconds, that might indicate you have some work to do on that part of the core. So if you're up for it, it's a great test to use as the Bunkie test to see what do you need. This height should be about 10 inches. So it could be a stair, it could be a few textbooks that you have sitting around. And then finally, calf strengthening. So thinking about that midfoot strike, how important the calf is going to be for a midfoot striker. And what we tend to find with people who have Achilles issues is that one of the main risk factors for an Achilles issue is calf weakness. The other risk factor being a lack of bend at the ankle. That's that mobility impairment. But really trying to work on your calf strength. Right? They're a powerhouse muscle group, but you want to try to work them into a single leg, thinking about eccentric loading. A lot of ways you can work on calf strengthening. Thinking about triple extension, working on hip extension, knee extension, and then ankle extension. So what you would use as you push off, think about the push off phase of the exercise. So he's driving the ball into the mirror. And then I love triple extension exercises. It's very efficient. You get a lot of bang for your buck as you work on hip, knee, and ankle extension. Again, working on that push off phase of the exercise. And then finally thinking about the core of the foot. Remember that our foot is designed to move, right? It's an amazing structure, 26 bones, multiple joints. It's acting like a spring. And we want to try to get these core muscles of the foot that's going to fill the gap between your heels and your toes to get stronger. So really trying to work on your arch strengthening of your intrinsic muscles, getting these muscles to work harder for you to reduce some of that force across your foot and ankle. If the muscles are weak, the plantar fascia is going to take more load and create more of that plantar heel pain. So if I had to summarize this into one slide that I see a lot for runners, it would be this slide here. If you think about a healthy runner, if you look at the first picture, the outer part of the circle is called your tissue tolerance. That's what the tissue can tolerate without becoming symptomatic. And as long as your activity level is less than your tissue tolerance, you can throw all of your activities in there. If you're a runner, if you like to hike, if you are cycling, all those activities go inside. And as long as your activity level is less than your tissue tolerance, you're going to remain asymptomatic. And what tends to happen with a training error is that you did too much too soon and you got too close to your tissue tolerance. So maybe what happened was you have a typical pattern of activity, and then your buddies wanted to go for a bike ride over the weekend that was going to double your intensity or double your duration. That's going to push the tissue above its limit, and it's going to become symptomatic. And again, that's going to be the common pathway towards overuse injuries, is that you did too much too soon. What we tend to find in the research is that a safe progression is about 20% from 1 week to the next. If you go above 20% volume, you're putting yourself at more risk. So the true benefit of strength training is it's going to take your outer circle and make it bigger. It's going to give you more capacity, more resilience to that activity. So when you're a strong runner and you're working on your strength, your tissue is going to be more resilient. Then when your buddy asks you to go for a ride and you do push yourself, you've got more of a window before you become symptomatic. So again, you just want to have more cushion and more room to maneuver, more room to make a mistake if you had a training error, versus a weak runner is going to have less room for error. So again, just provides that cushion if you're a stronger runner. So I strongly encourage runners to be strength training as well. So this is that study we talked about for 20%. But the final category of our pyramid is going to be training volume. And we want to try to look at controlling training volume, giving enough training to produce a beneficial effect, giving you a better VO2 max, becoming a better runner, but not too much of a load from 1 week to the next. It's going to put you at risk to injury. So in this study, they looked at 260 runners training for an upcoming half marathon. And what they found was that 1 in 5 of these runners reported an injury. And when they looked at the injury of those 20% of those runners, they wanted to determine, was there anything that changed in your training progression that may have put you at risk for the future injury? And what they found was that the runners that were injured most likely had increased their volume from 1 week to the next by 20%. So that 20% value is conservative, and I know that it's conservative, but it's going to keep you healthy looking at that progression from 1 week to the next. Right. So easy way to think about that is if you're running 100 minutes per week, if you want to add 120 minutes the next week total volume, that would be 20%. If you go less than that, that'd be less risk. If you went above 120 minutes, that would be a higher risk of injury. So to measure that risk, a couple authors have written about this in 2013 and 2016, looking at the acute, that's week that you're in, to your chronic workload, which is your 4-week moving average. So if you look at your training volume on your schedule, you want to get your total volume per week for a 4-week average. That's going to be your chronic workload. That's what your tissue is used to. That's your tissue's capacity. Then you want to look at your individual week that you're in right now and what you have planned to do for training. That would be considered your acute week. So if we look at this graph here, this is just an example, but in the first row, what we see is week 5, and you wanted to run 90 minutes. And then you want to give it an intensity value where 1 is getting out of bed in the morning and 10 is your maximum effort. So we might call it a 6. And you would multiply those two together. So as you multiply those two, you get your met minutes, or how intense that exercise was, which is about 540. And that's consistent with what you did over the last 4 weeks. So you can see that the number was 1.0 when you divided the week that you're in, your acute week, divided by your 4-week average. So again, you're on par with what you've been doing in the past. So really not much risk there at all. If we get into our week 6, we can see that we start to increase the amount of minutes that we're doing per week. And if we have that value divided, again, dividing the week that you're in by the 4-week average, as you get into the yellow, when you're between 1 and 2, you're thinking about this progression of load. Nothing wrong with that. You need to have a progression of load, but you're just kind of in this cautionary area that you know that you're increasing your load, and you really have to monitor your symptoms and determine, am I making a big jump from week to week? Am I ready for this jump? Should I stay at the same week before progressing to the next level? And then finally, in this 9th week, I kind of showed you what happens if you increase too much too soon. So in this patient, they had been running, their 4-week average was about 800 or so met minutes. And in this week, they did a big jump in volume, right? We had a really hard week. We bumped up the volume, the intensity, the duration of the run to about 1800. And when you divided those numbers, you see that you get above a 2. And when you get above a 2, you're at risk of injury. So I really would encourage you guys as runners to keep a training log, maybe on your phone or on your computer or just on pencil and paper, and really write down what's your 4-week average of what you've done in the last 4 weeks. And then considering that average, look at what you're going to do this coming week and see if it's a reasonable change from the 5th week to the previous 4 weeks. So you're going to keep yourself healthy, keeping yourself in that between 1 and 2 level range, and not exceeding a 2, which puts you at a higher risk of injury. So one thing we hear from injured runners is, how much soreness is okay? Well, it really depends on the injury that you have, but in general, you can kind of use these soreness rules. That if you had a soreness develop in a tissue that was there when you warmed up, but then you kind of felt it the longer that you ran, it kind of stayed at the same level. It didn't worsen, it didn't get better. What we'd ask you to do is take 2 days off of the activity like running, and then probably reduce your volume by 1 level, right? Because you're probably getting close to that level where you're exceeding the tissue capacity. Now, if your soreness came on during the warm-up, but then it gets better and goes away, that's pretty classic with a tendon. You're probably at the right level of activity, and you want to stay there until that soreness goes away before you progress to the next level. Okay. So what about if that soreness goes away, but then it comes back at the end of the session? Then you're going to kind of be in that same first row. You're going to take 2 days off and then reduce your level of running by 1. Okay. Now, oftentimes with a tissue like a bone, we might see that the pain is not during activity. It might be afterwards. So maybe that evening, that night, the next day, you start to experience soreness in the area. So what you want to try to do in that scenario is that tissue is probably healing. And you want to give it at least 1 day off, but not make any progressions. So oftentimes I want to see a runner get at least 2 or 3 runs in at the same relative running volume before we make any adjustments in their training run. So not making a big jump after just having 1 successful run. You've got to get 2 or 3 successful runs in at a given training level before we make that jump to the next level. So in summary here, main thing is that know your limits. So what is your tissue's capacity? We know we can improve your tissue's capacity through smart training. We can improve your capacity through strength training, but try to prevent that overload of the tissue, which is that common pathway to injury. Okay. If you're experiencing any pain, I would really seek out a really knowledgeable physical therapist. They can really be an excellent resource for you to really educate you on what's going on, what are the contributing factors, what can you do about it, and maybe what treatments you might require to get better. Think about you as a runner and try to identify your weak links. Are you working on a strength training program that's going to be working on your individual weak links? So it could be the Bunkie test, looking at which part of your core is weak. It could be which part of your hip is weak, which part of your knee is weak, what you can do to make yourself a more robust or more resilient runner. Again, we can't prevent injuries. They're going to happen with all sports, but we're just trying to reduce that risk of injury through smart exercise. And then finally, we're around as a resource. We've got great information on our social media posts. We offer free consultations where runners can come in for no cost and meet with a physical therapist for 60 minutes, and we can really kind of triage the situation for you, give you the knowledge that you need to take care of yourself. Here's that page for YouTube if you're interested in any of our videos. We've got great videos on there for runners, as well as different conditions across the body that we treat. So once again, thank you for attending this lecture. I hope you enjoyed it. I hope you learned something. Again, think about the pyramid, that usually what we find is the easiest thing to do, like buying a new pair of running shoes or buying an orthotic. It seems like, wow, this is going to be really easy to fix my injury. But like the old saying, if it's too good to be true, it probably is, right? So we're going to try to focus on the things at the bottom of the pyramid that do require time, do require effort, but the smarter you can train, the less of your risk of injury. So feel free to reach out to us through our website, through social media. We'd love to hear from you. And if you have any questions, please let us know. Thank you.